So good morning everybody. I would like to brush up the last class and go through the today's class. So in the last class we have studied opioid receptors. What are the different types of opioid receptors? Mu, delta, kappa receptors are there. How their mechanism is different from the regularly using sedatives and hypnotics. So we have studied something about the fibers which carry the impulses for the pain transmission. Okay, so we have studied about this fast A delta fibers, slow C fibers. Okay, so the tracts which carry the impulses for the pain are the spinothalamic and the spino-reticular tracts. Okay, here is what we can see, the spinothalamic tracts. Here is the reticular activating system which can both influence both the pain transmission and distribution. So we have studied about this mu, kappa and delta receptors, but mu receptors is the one primarily involved in pain transmission in this opioid receptors. So where they are located? Located at the spinal and the supraspinal sides. Okay. Kappa, again they can transmit this analgesia, miosis, sedation. All these properties can be seen on activation of these kappa receptors. But in dinorphin, it is primarily involved in dysphoric reactions. Delta receptors on which our endogenous enkephalins will act. Okay, so you need to remember on mu receptors endomorphins are acting, kappa, dinorphin, and on delta receptors enkephalins are acting. All these are endogenously released substances which can alleviate the reaction to this pain. Okay. Then we have nociception, opioid receptors. Okay, it can produce both biphasic hyperalgesia and also analgesic response. So opium alkaloids, it is derived from the papaver somniferum. Okay, so we have phenanthroline derivatives and benz-isophenylene derivatives. The most commonly used pharmacological agents are derived from this phenanthroline. Okay, morphine, codeine, Pethidine. You already know some of the characters of these agents, but benz-isophenylene derivatives, their effects are less prominent and they need to be explored. So coming to the agents which are acting on these receptors, opioid receptors, mu, kappa and delta receptors, we have agonist, partial agonist, antagonist and semisynthetic opioids. Morphine, codeine, morphine, codeine, levorphenol. Partial agonists are nalorphine, levonorphan. Antagonists are naloxone, naltrexone and nalmethane. So presence of these antagonists will help us to treat the patients with these opioid abuse. Okay. So we have this semisynthetic agents such as hydromorphone, hydrocodone, oxycodone and desomorphine and heroin. Heroin is the most abused drug, banned in most of the countries. Synthetic opioids, we have this fentanyl, which is 100 times potent as that of morphine, okay, Pethidine, then Alfentanil and Fentanyl. Pethidine is about 1/10 effective as our morphine in analgesic effect. Still, it is more commonly used because of its cost and availability. Tramadol, the drug with multiple mechanisms of action, action on mu receptors, action on the 5-HT receptors. Partial agonists such as Pentazocine, Tridine, labor analgesia, then buprenorphine, butorphanol, all these are there. Loperamide, which is a drug which cannot cross the blood-brain barrier, still has some of the morphine effects. They are commonly used for their constituting effect in cases of diarrhea. Diphenhydramine, then dextromethorphan, they find their use in the cough suppressing syrups. So we have studied that these mu receptors, kappa receptors, all these are having a structure similar to our G's protein coupled receptors or the GPCRs. Okay, so the downstream pathway is mainly based on the activation or decrease in the synthesis of the cyclic AMP levels, and the minor mechanism of action is activation of the potassium channels and also on inhibition of the calcium conductance. So analgesia, respiratory depression, they go hand in hand. Okay, more the analgesia, more the chances of respiratory depression. So euphoria, it is the one which has driven most of the persons for its abuse or addiction. We can tell these things. Okay, so we have to see that this character is dangerous and can cause addiction. Sedation. The sedation which is produced by our classical hypnotics is different from that which is produced by our morphine and their derivatives. Why it is so? Because there is indifference to the surroundings. The person feels he is dissociated from his surroundings, and there is motor incoordination and ataxia also, which is commonly seen with alcohol. Okay, so it is more likely to occur with elderly, less likely with synthetic opioids, and additive action with other CNS depressants. So on the gastrointestinal tract, we told that it has constipating action. Because of its constipating action, we are using it in diarrhea cases, and it is also a non-CNS penetration. Okay, they cannot cross the blood-brain barrier. So histamine release and action on the blood pressure, these are the other side effects. So biliary tract, we cannot use in any type of pain. Here we need to avoid it in biliary tract pain. Okay, so biliary colic can be aggravated by our drug. So the sphincter can get the spasms, thereby we can aggravate the biliary colic, maybe due to stone or any other condition. So urinary bladder, again it has a negative effect. The bladder wall is relaxed but the sphincter is collapsed. Okay, so here also urinary retention takes place. It can be dangerous. Bronchi, it can, once the drug which can here is a drug which can release histamine. Histamine releases more secretions, and the person can be drenched in his own secretions. It can lead to bronchoconstriction also. ANS, autonomic nervous system, we have noticed that this drug can release the glucose or gluconeogenesis can take place, and there can be hyperglycemia. So it may be bad in cases of diabetes. So we have discussed about this histamine release. Then at high doses it can cause muscle rigidity and immobility. It resembles catalepsy in rats. We have discussed what is catalepsy in the last class. So convulsions can occur. Okay, we have discussed that the inhibitory neurotransmitters such as GABA, its enhancement or the inhibition of this glutamate receptors. Okay, glutamate is the excitatory, GABA is the inhibitory. Any alteration which can be produced by our opioids can lead to aggravation of this epileptic attacks. Okay, here what is happening? The procholinergic action is due to inhibition of the GABA as an inhibitory. Inhibition of this inhibitory effect can trigger the hippocampal interneurons, can cause epilepsy. So CTZ is the center which monitors our vomiting. Okay, so morphine can stimulate nausea and vomiting and depress the vomiting center directly. So both in morphine abuse or withdrawal we can see this nausea and vomiting. Meiosis, you need to remember this is a special type of meiosis, not by topical application but by its central action. Okay, so there are two characters of this opioid receptors. Okay, tolerance will not develop to the constipating effect and also to the meiotic effect. So any person who might have come to your OPD, you can see that there is meiosis. Okay, you can think there is a injection marks, there is a chances of drug abuse. Okay, all these things are there. So differential diagnosis are, we discussed it in the last class. What are the differential diagnosis for pinpoint pupil? Pontine hemorrhage, cerebral malaria, opioid poisoning, and organophosphorus poisoning. What you can get? OP poisoning. So all this is there, but along with that you need to remember sometimes we take the blood and analyze the blood for the constituent which may be present. So opioids sometimes may be very high because the tolerance. Okay, that will not guide you to treat the patient. Okay, the guidance factor for you for the treatment in case of this opioid poisoning should be the pupillary constriction, because tolerance will not help to this property. So endocrine, there is inhibition of the release of this ACTH, prolactin and gonadotropic hormones. So pregnant women, it may be dangerous. So impaired water exhibition by increased antidiuretic hormone. So urinary bladder, we have explained this. Last class we have studied about this morphine, some primary characters. Okay, TF is around 1 to 6 hour, high first pass metabolism, hepatic metabolism by glucuronide conjugation. Okay, so morphine 6 glucuronide and morphine 3 glucuronide, both are there. They again have this active potency somewhere around 13 times more potent than morphine. Okay, in chronic kidney disease we need to avoid this drug. Diacetyl morphine, mostly abused drug, very less or no therapeutic effect. Okay, it is chemically diacetyl morphine. So the side effects may be due to the production of this euphoric effect, as it can cross this blood-brain barrier. Okay, T-HOP is approximately 5 minutes, and where it can be converted into 6 monoacetyl morphine. Codeine, we discussed in last class that it is a drug which can be given orally. Okay, so oral availability is just 50% of the intravenous availability. So it is more bioavailable than the morphine. Okay, so that's why it forms the most important constraint of the most of the suppressant or the antitussive agents. So used in treatment of mild to moderate pain also. Here we need to remember codeine, unless it is converted to its active metabolite, it cannot be acting as an analgesic agent. Here codeine per se doesn't have this analgesic action. So TF here is around 2 to 4 hours. The side effects such as constipation is less, CNS depression, sedation, all these things are comparatively less with the codeine. So antitussive action is better than that of morphine, oral availability, less constipating and less respiratory depression. So codeine, it's not an analgesic unless it is metabolized. Okay, up to 10% are poor metabolizers. That means in these patients there will not be any analgesic effect. So rapid metabolizers, they have the analgesia. So Pethidine, Meperidine. Okay, so this is the drug which is 1/10 of the effect of this morphine, but still it is commonly used. It is not available with any of the pharmacists. Okay, it is given directly to the hospital for the use. So intramuscular, rapid onset and short duration for action. It has antimuscarinic action. Antimuscarinic is nothing but anti-cholinergic like action. Okay, you need to remember what will be the side effects you can expect here. So it has additional sedative and euphoric action. Norpethidine, the metabolite, can have this CNS stimulation, tremors, restlessness and convulsions. So it is used in labor anesthesia and also as a pre-anesthetic medication. Coming to Tramadol, okay, Tramadol we told that it is a drug with multiple mechanisms of action. It acts on Opioid receptors, it inhibits the reuptake of this noradrenaline and 5-HT, that is 5-hydroxytryptamine. Reuptake is inhibited means their concentration is increased. Okay, so it can increase the concentration of this 5-HT and noradrenaline. So it is effective in moderate to severe chronic pain. So now they are tried in osteoarthritis with hypertension patients because their NSAIDs can cause shortened water retention and aggravate the blood pressure. Here, Tramadol will be helpful in such conditions. So the maximum dose which can be given is 416 mg. It is given in cases of postoperative neuropathic and labor pain. So it is available in both oral preparation and also in the form of intravenous, intramuscular injections. Methadone, okay, Methadone is a drug, it is a mild partial agonist, okay, something like morphine. Here this is a drug which is used as an opioid replacement. For example, in smokers what we use to cessate their smoking, nicotine patch is used, nicotine chewing gums are used. Something like that, this drug is one which has less addictive or less habit forming form. Okay, so we try to replace the abuse drug with this methadone, so that the person will still have the similar effect but less addictive. Okay, supplied as a racemic mixture like L-methadone is a mu agonist, T-methadone is an NMDA receptor antagonist. It is a synthetic drug, long acting. Okay, we need to remember morphine, we told that T-half is around 3 to 4 hours, but here it is a long acting. Longer the drug is active, more will be the pleasurable effects. Okay, so less frequent will be the drug administration. So half-life is variable, average is around 24 hours, highly lipophilic and good in renal dialysis. Okay, that means in case of renal compromise also we can use this drug. So the route of administration, you can see it has wide range here. It is tried in neuropathic and cancer pains and also in opioid de-addiction. Okay, opioid de-addiction is an important point you need to remember. So the next drug is fentanyl. So fentanyl was tried initially for neural analgesia. You might have heard about this neural analgesia. Where did we use this term? Neural analgesia. Do you remember? General anesthesia class is over for you. General anesthesia, neural analgesia, fentanyl plus droperidol. Here is a drug. It is a synthetic one with longer T-half and 100 times potency as that of morphine. It is a mu and kappa receptor agonist. Okay, so the action will be similar to the morphine but highly effective. Okay, so highly lipid soluble. So the most of the drugs which are more potent than morphine, they should be highly lipid soluble. Okay, so it is a highly lipid soluble, safer in cardiovascular surgeries. So used as a pre-medicate before surgery and for treatment of moderate to severe pain. No, it's not a histamine liberator. That is a relief factor for this cardiac surgeries, because when we use it in cardiac surgeries, we need to think that there is no hypotension also. Okay, so here by the release of histamine, which was one of the mechanism whereby blood pressure was reduced or it would have led to hypotension in morphine. So here it is a not a histamine releaser. T-half is around 3 to 12 hours. So it is used in neural analgesia combined with droperidol. Okay, so it can also be used for this obstetric analgesia. So adverse effects are muscle rigidity and respiratory depression. So we need to remember, more the analgesia, more will be the chances of respiratory depression. They are directly proportional dose related. One more consumer of this fentanyl. Okay, the plus point here is it is a synthetic phenylpiperidine derivative, mu receptor agonist. Okay, high lipid solubility, about 90 times more soluble than morphine. Okay, then compared with fentanyl, it is less lipid soluble and onset of action here is faster. So mixed agonist antagonist, that is pentazocine. Here you can remember it is antagonist or partial agonist at these mu and kappa receptors, whereas mu and delta receptors, agonist at this kappa receptor. So pentazocine is a popular question for your exams, short notes. Okay, so they will be having this tendency to know where it is acting as agonist, which is the partial agonist of this group, or which is the mixed agonist drug of this group, like that. So you need to remember such drugs in each class. Okay, so do you remember adrenergic receptors, which are agonists, mixed agonists? Labetalol, carvedilol, all these are. Okay, so they are actually blockers. Okay, so here is the agonist. So actions are less potent compared with the morphine because of the weak antagonistic and agonist partial agonistic action. So respiratory depression, in instant euphoria, all this will be comparatively less to morphine. Dysphoria, hallucination, hypertension at high dose, these can be the side effects. So they are tried in moderate to chronic pain, obstetric analgesia. I just want to concentrate you on this table, volume of distribution. Have you heard of this term, apparent volume of distribution? Yes? Okay, so the first example you should come to your mind for this apparent volume of distribution should be morphine. Okay, here you can see that there is 224 liters. What is the normal body water content? About how many liters? Yeah? Approximately around 40 liters. Okay, so among this, some of it will be intravascular, extravascular, intracellular, extracellular. All these classifications are there. So if it is all united also, it is not this much. It is about 5 times or 6 times more than that. Okay, so this is apparent volume of distribution. Even though the plasma payoff is less, because of its apparent volume of distribution, the drug can be active for longer time. Here you can see fentanyl. Again, it is about 335 liters. So coming to the opioid antagonists. Opioid antagonists, what are these? Naltrexone and Naltrexone. Okay, so Naltrexone is the classical one, but it is not orally active. We need to give IV, and the half is very less, about 1 to 2 hours. Okay, so repeated administration will be necessary. Whereas the newer agent, that is relatively newer one, Naltrexone, TF is approximately 10 hours. So, and it can also be given orally. So, when comparing, Naltrexone will be better here. Okay, but it is the Naltrexone is the prototype drug used to reverse the respiratory depression, as a diagnostic text for opioid addicts, and also treat addiction of the withdrawal. It is Naltrexone is a competitive antagonist, and it is a pure antagonist, and it is used to treat this withdrawal syndromes in morphine addicts. Okay, given as IV because less orally available, uses in morphine overdose, neonatal asphyxia. How can neonatal asphyxia take place? Because you might have used in some of the opioid agents for painless labor. Okay, you use some of the drugs, maybe Pentazocine or other drug, Methadone. You might have used some drug where it can lead to neonatal asphyxia in some cases. That's why these drugs are rarely tried. So, and also it is used for diagnosis of opioid dependence. Coming to the next drug, Naltrexone, we told that here it can be given orally and also longer acting. Okay, Naltrexone is different that it is orally administered, longer duration of action. So, indicated for treatment of alcohol abuse. You need to remember these drugs can act at NMDA receptors also. Okay, opioids have their action on NMDA receptors also. That's why antagonist of opioid can be helpful in treating the alcohol abuse. Okay, Naltrexone is tried. Do you remember some of the drugs which can be used for alcohol abuse? Disulfiram, very good. It has an antagonist property by acting on the enzyme. Aldehyde dehydrogenase. Yes. Which is the alcohol dehydrogenase inhibitor? Omeprazole, alcohol dehydrogenase, disulfiram, aldehyde dehydrogenase, metronidazole, aldehyde dehydrogenase, ondansetron, aldehyde dehydrogenase, risperidone, taxol aldehyde dehydrogenase. Then what else can be tried here? We use some of the sedative drugs, chlorodiazepam oxide, clonazepam. Okay, there are so many drugs we try in this withdrawal syndrome also. Okay, then we have some of the terms you need to remember. Addiction, tolerance, dependence. What are these? They are the same or the different. Okay, so addiction. The person knows that after using this drug I can have some problems. Okay, but he tends to use this drug. That is loss of control over the drug use, compulsive drug use, continued use despite the harm. Then we have physical dependence. That means after stopping the drug, there can be reversal of action. For example, in case of opioids, we told there is euphoria, respiratory depression, and GI constipation will be there. So all these symptoms can be reversed. Okay. The person will be go for dysphoria. The person can go for respiratory excitation, ventilation. Okay, all these things can be there. So this will be the withdrawal symptoms. We will be learning it in the later slide. Tolerance. Okay, less effect after prolonged use. This we have discussed comparing with the smoking and also alcohol use. Escalation of the dose will be required to maintain the effect. So this escalation of the dose, sometimes what will happen, the person is taking escalated dose or very high dose. Sometimes it may be like we normally think as a toxic dose, but for that person it may be the normal dose required for his euphoric action. So that's why the blood levels of these opioids may be misinterpreted at the time of the casualty administration. Okay, so we need to go for the more other symptoms which are more reliable, that is meiosis. So tolerance, here it is having negligible tolerance to meiosis and constipation. You need to remember these 2 points. High degree of tolerance developed to the central nervous system effect, that is anesthesia, euphoria, sedation, respiratory depression. The person can be overcome with all these things. After some time he will not feel analgesic, not a euphoric drug, and not a respiratory depression drug for him who has abused it. Okay, requires increased dosages on long-term users. So increased survivability at high blood concentration. This point is very important. So you may think that the person is already having toxic dose in his blood. The person may die. Anyhow, we have to treat the patient. That may not be the condition, because after prolonged use, the survivability of the patient will have increased. So we can give a shot to make the patient or make the patient survive by giving appropriate dosage of the antagonist or the antagonist. So conclusion about toxicity of the opioids cannot be drawn by the blood levels alone. So this is what I was trying to explain. Okay, coming to the abstinence syndrome and opioid effects. Okay, you can see analgesia, withdrawal, there can be increased pain, sedation, agitation, insomnia, euphoria can go to dysphoria, pinpoint to dilated pupils, low BP, pulse rate and respiratory rate, here it can be increased, dry skin, hyperventilation, sweaty, urine increases. Okay, urine has decreased. Why? We told you the bladder muscle, upper part, they can be relaxed, okay, muscle rigidity, but the sphincters can be constricted. Okay, the person has the urgency, but he may not be able to do so because of this effect. Constipation, bowel action, then it can be replaced by diarrhea, abdominal cramps, hypothermia, nausea, vomiting can be seen in both. So it is not a characteristic feature there. Coming to the next drug, the drugs which can cross this blood-brain barrier cannot cross this blood-brain barrier, but still have some of the opioid effects. Okay, these drugs can be utilized for the effects in cases of diarrhea. So activation of mu receptors decrease the peristaltic movement. Okay, activation of the delta receptors contributes to the anti-secretory effect. You might be knowing there is prolonged activation of the cyclic AMP receptors in some types of diarrheas, maybe in cases of cholera also. Okay, so this anti-secretory effect is there by activation of this delta receptors. Then we have this loperamide, it can directly stimulate the mu and the delta receptors. Racecadotril is a newer agent which can be used safely in the children below 5 years. Loperamide is contraindicated in children below 5 years. Okay, because the children below 5 years, they are more susceptible to go to the intussusception or volvulus. Do you remember these terms, intussusception, volvulus? What are these? These are a type of intestinal obstruction which can take place in children. Okay, so racecadotril, it can block the enzyme N-cephalokinase and increases the local concentration of the N-cephalins with the intestinal mucosa, which then can be stimulated by mu and delta receptors and can be used for the children around children less than 5 years of age. So, just summarization, we already know this, okay, where our opioids can be used. Opioids more commonly used for analgesia. Okay, so it may be preoperative, postoperative, intraoperative, okay, and labor analgesia, obstetric, war zones, MI. There are various others. Okay, you can make more than 100 reasons where we can use this analgesic effect. In severe diarrhea, we can use this loperamide. Why we added this severe? Because in all cases of diarrhea, we never tend to use this drug. Okay, so we want to remove the toxins also there. Okay, that's why we prefer to use the antibiotics, which can take care of this increased cyclic AMP levels by destructing the toxins, and also we use probiotics. Probiotics, antibiotics, zinc contained preparations, and ORS form the primary line of treatment for diarrhea. Okay, so but if the patient is having a lot of water loss, and after the third dose of this antibiotic, we tend to use some of the anti-diarrheal agents such as loperamide. It is not definitely not the first line of the drug which is tried in diarrhea, but in over the counter, it so happens that loperamide is the one drug which is given primarily. Have you noticed it? No, no one has tried loperamide. In the hostels, no one has tried this loperamide tablet, yellow color capsule for diarrhea. No one has used it. I am sure at least half of the class has used it, because it is the most common on the table available drug. Okay, so it so happens that it becomes a toxic cycle. You prevent the outer coverage. Okay, well, that's what you are doing by using loperamide. What you are doing, you are closing the